Which
Okay.
side, when you come to ilioinguinal, iliohypogastric, you better confirm the side on which the surgeon is going to get operated, the patient is going to get operated. Yeah, sorry. This is the right-sided inguinal hernia. Okay. He is 9 years old and 20 kilograms.
Vrushali, we are dealing with a case which, what surgical problem you said? Hernia.
Yes, hernia.
Yeah, please give us the details about surgical procedure to be carried out and just go on talking.
Yeah, sure. Where is the other mic? Maybe somebody else can brief till I keep things ready.
Can anybody from the
Yeah, that's exactly what I said.
Poonam, is there any positive history of the patient?
Any positive history?
He is ASA grade 1 patient. No other comorbidities.
Usually hypertensions, diabetes, low ejection fractions are gifts for adults. So we are lucky. Take it up.
Any sedation given or what?
Yes, yes, the child is sedated. Maybe you can tell how you do it, how you did it right now.
What has been given?
Yeah, she's telling you.
Okay.
We gave midazolam, glycopyrrolate and ketamine before bringing the patient inside. Now I have given few doses of propofol and hold the mask with sevoflurane, nitrous and oxygen.
So do we need regional
Spontaneous
anesthesia?
ventilation.
Who was that?
This is a neonatal dose which we are giving to the adults. Don't worry.
No, but who was this? Was this? No, whose brilliant comment was this? Is what I want to know.
Anyway, Vrushali, this is Dr. Ponde. Jokes apart, but we need to details what sedation was given.
Yes.
And she didn't give us the clear dosing of the patient. What it's saying.
Yes. No,
So
great.
I still want to know what exactly has been given. How much midazolam, how much ketamine, how much propofol.
Okay. Well, I know about it as little as you do because I am just dragged in this theatre and I beat her in.
Anyway, audience wants to know how much sedation was adequate for this baby.
Sir, sedation was given according to per kg body weight. Ketamine was given 2 milligrams per kg since we have given the IV dose. So he is weighing 20 kg, so 40 milligrams of ketamine was given.
Okay.
Glycopyrrolate was given 0.1 milligram and midazolam was given 0.003 milligrams per kg body weight.
Get it here so that I can see.
That comes to around 0.25
Give me 10
milligrams
cc
per
syringe,
kg.
please.
Fine, thank you.
Yeah, okay. Is everybody happy with this?
Yes, yes, very happy with the general anesthesia.
Very good. Now we can go ahead with the regional.
So much of a distance from here and you can still feel it very good.
0.25. No, now I better be serious because I'm loading my drugs.
That's what we are expecting, but things are just not happening. Vrushali, what are you taking now in the syringe?
0.25% of bupivacaine.
Yes.
I am just loading around 0.5 ml and obviously I don't intend to give the whole thing. But this is his dose that can be very safely given to him. Okay? So if we agree on this, we can go ahead.
Please go ahead.
Can you give me betadine filled? Can you get it here and keep it? Okay, now the probe is kept on the anterior superior iliac spine. Please don't look at my gloves that are not my size. My size is very special and it's not here.
No
My size F gloves. Okay, now concentrate on the scan here, please. Fine. Okay, we will, all those who have not attended the pediatric workshop, this description is for all those. Let me read the scan. This is the anterior of the abdominal wall. That is, this is the posterior of the abdominal wall. This is my end, that is the lateral in this case, and this is medial.
Okay.
Am I clear?
Yes, yes.
Okay. Now what I want, the structure that I want to see is rather superficial, so I will just request her to decrease the depth a bit. When you're in a workshop, you're in absolute luxury. Somebody keeps a patient ready for you, and then somebody adjusts the machine for you, and all you need to do is a bit of chatting and then show the block.
That's what we are trying to do.
E.
The depth is now 2
The depth is
centimeters.
around 2 centimeters, and I guess it's all right. Now let us read the muscle layers. The ilioinguinal iliohypogastric as such is a bit medial to the anterior superior iliac spine. Let us forget about how many centimeters medial and how many centimeters lower than that, but let's start reading the ultrasound image. So after the skin subcutaneous tissue that is here, you see one muscle.
Okay.
Yeah, that's the external above. Yeah. Then you see another, no, this one. Yes. Then you see another one below that, the internal, and this is the transversus. Now can you see these two structures here? These are ilioinguinal and iliohypogastric nerves. Is it clear?
Yes, very, very clear.
Okay.
Yeah.
So my job is just to put the local anesthetic around them, and that's going to be the block. Okay. Can you see the bowels moving here with respiration?
Yes, we can see.
Okay. So I know where not to go and I know where to go.
Vrushali, why not their vessels? Why not blood vessels? Why do
They
you
look
think
like
that?
blood vessels.
No, there could be there.
Why don't you put a color Doppler?
Okay. Let's put a color Doppler.
They were seeing hollow, hypodense, and that's why the doubt.
There could be an artery accompanying it. I wouldn't deny that also, because it's a neurovascular bundle that is moving. So these are the two nerves that I'm working on. Yeah. And this is one very important aspect in pediatric anesthesia is the child may be under light GA. When you are about to puncture, please confirm that the puncture is not felt by the baby, because this is a classical scenario to precipitate a laryngeal spasm. If the child is light and you gave a painful stimulus, then fine, you get a laryngeal spasm. Quite often they're not. But this child is very fine, so don't worry.
So you are in plane now, injecting from the lateral side.
Yeah, I am in plane and I'm going to go ahead and keep my needle adjacent to the nerve and do the job. I would have liked the depth a little more lower, but I guess in this machine we can't go lower. That's a little late. Okay, we get our nerves back. Let's go a little down, because can you see the can you see the needle?
You can see the
Okay.
needle advancing towards the structures which you showed.
I am sitting on the posterior aspect of the two nerves. Is that clear?
Okay, we can see that needle tip is in proximity with the structures which you showed.
I'm aspirating it. Anyway, aspiration here is a matter of habit, and it should be a must no matter what you give and how you give and which modality you work with. Okay, and I guess I'm putting in fact too much of volume, so I'm stopping at that. I have given around 2 cc's.
Okay.
All right. So this was the ilioinguinal iliohypogastric block. Maybe I can call it a very simple block to give in pediatrics, but I also want the audience to know that this is not a block that the whole surgery can be done under. All right. It is a it is a add-on to the surgery, and it should not be taken as the end all of it. It will be more for analgesia, postoperative analgesia purposes.
Okay, Dr. Ponde, can I?
Yes, yes.
Yeah.
Is there one
questions
question?
for?
There's a question, Vrushali. Just listen to the question.
Yeah, Vrushali, this is Maruda.
Hi.
I just wanted to ask you about your gel, the sterility of the gel you're using. Is it a sterile gel or the ordinary gel you're using it, because you're going to introduce with the needle inside?
You know, this is a tegaderm which is tightly hugging the footprint. There is not even air in between here. So I am using betadine on this. So leave alone air, betadine will also not reach the footprint and I won't damage it. So this is betadine which I am using as jelly. So the coupling agent here is betadine.
Oh, so you're not using any gel there.
No, I am not using any gel. We are quite comfortable with betadine, obviously, but with a tegaderm protecting the probe so that it doesn't get stained.
Okay, that's good.
And obviously, any damage is because of betadine to the piezoelectric crystals here. Well, I'm not too sure about that, but since it is very protected well with tegaderm, we do not do that.
Okay, the second thing is the volume we inject was only over 2 mils, and you said it's going to be adjunct for post-op analgesia. So you're not going to use it for anesthesia purposes, isn't it?
Yes.
Okay, well, what is the minimal dose you use? Only 2 mils, or do you have any?
No, actually, if you really count the dose in here, it is hardly 0.1 ml per kilogram that you can do do this particular block as such. And there is one more thing. The more all my pediatric surgeons, most of them are uncomfortable with this kind of a block, maybe because they have this view that it mars their plane of working. So ilioinguinal iliohypogastric block for hernia is, in my practice, is usually not that way. We go caudal and we give a big volume and a dilute solution to go till the level of above the, at least T12, T10. So
Yeah,
if I want to do a case with light general anesthesia with mask and then give a strong caudal, then that would be for me as a private practitioner better than an ilioinguinal iliohypogastric block that probably will not render the entire regional block as such. Okay.
Yeah, that was the next question I was going to ask you, because some surgeons object giving
Yes,
island
yes,
because
and
it does, alter
yes.
your anatomical planes for them to dissect.
You don't practice in India, right?
No, but still.
But so surgeons all over the world are the same, I think.
Yeah, the surgeons
Yeah.
are the same, yes.
Okay. All right.
With ultrasound precision, are you able to minimize the dose by any chance here as well as in many other blocks? Can you say that? The volume, can you decrease the volume because you are very near to the nerves?
Right now, yes, you have just seen an example of we decreasing the volume. Otherwise, we would have given at least 0.2 ml per kilograms for for this hernia block. We would have taken those 2 pops and then injected at least 5 to 6 ml in this kid, right?
Okay.
So yes, there is definitely an advantage of decreasing the dose, but at the same time, if I was to if he was an adult and I was to give a block here in the interscalene for a fracture, proximal humerus or subclavian perivas, I wouldn't have withhold the entire volume. I would have given decent volume so that I do not lose on the duration of post-operative analgesia.
Okay.
About the coupling,
And as far as caudal goes, you can't not give that volume because the drug will not reach higher up.
Yeah, that's right. We know
Yeah.
that. Yeah. That is a space which you are filling with. Here it is just to go around the nerves. Swarup has some questions.
Yes.
Not questions actually, it's a comment. Vrushali, I think both blocks are done very well. Very nice.
Thank you,
and
Swarup.
Very appreciated. And you are welcome to Australia because we got a close number 4 onwards. So it's
Anytime.
thank you.
Vrushali, about the coupling agent, how about using the distilled water or normal saline instead of betadine or jelly?
Yes, why not? Even sterile water will give you an image.
Any other question? I think so, Vrushali, it's very well done blocks. Can we move to the next one now? So,
Yes, thank you very much.
thank you.
Yeah.